I'm Dr. Teresa Zesiewicz. I'm from University of South Florida. I'm the director of the USF Ataxia Research Center and the Francis Zesiewicz Parkinson's Disease Foundation in honor of my mother, who died of Parkinson's disease as well. And I'm so happy to be here today with you. And we're going to be talking about the diagnosis and treatment of another terrible disease called multiple system atrophy. So multiple system atrophy is a rare neurodegenerative disease. It's characterized by misfolded inclusions of what we've heard this morning is called alpha-synuclein. And alpha-synuclein is the abnormality that is found in Parkinson's disease, and it's misfolded and it's aggregated, and you heard it from Dr. McFarland's talk. And, you know, multiple system atrophy can look very similar to Parkinson's disease at first. But as time goes on, you know that something is not quite right and something is different. These patients are different. Part of the problem is that they don't respond to levodopa as well as a Parkinson's disease patient would. And it's a clue or a red flag that, hey, maybe this person is dealing with something a little bit atypical. It's an atypical form of Parkinsonism, just like progressive supranuclear palsy is. And when I started or graduated 30 years ago, you know, we still call this by several terms: Shy-Drager disease, striatal-nigral disease, or all these fancy forms, olivopontocerebellar atrophy. What they did is they referred to Parkinsonism and problems with blood pressure and autonomic nervous system and poor response to levodopa. So this disease, the historical roots go back to the early 20th century when two French scientists, Desjardins and Thomas, they were neurologists at the Salpêtrière Hospital in Paris, described two patients with adult onset sporadic ataxia. And they called it olivopontocerebellar atrophy. And this is because there are parts of the brain that were affected. So part of the brain are the olives. Part of the brain are the pons, right? That's the brainstem, or the cerebellum. So that's what they called it. Well, they said, well, all these parts of the brain that are affected, we're going to call it olivopontocerebellar atrophy after the parts of the brain that are affected. Then in 1948, Critchley and Greenfield said, well, you know what? This is a real thing. This is a real disease, okay? It has different names, Shy-Drager, which I knew as a resident, striatal-nigral, whatever. But the unifying concept is that these are all part of a syndrome by Graham and Oppenheimer in 1969 that they called multiple system atrophy. And why is that? Well, there's multiple systems of the brain that are affected. Okay? It can be called multiple system atrophy P or C. If it's a P, you've got more Parkinson's. And when we talk about Parkinson's, we're saying that you are slow and stiff and have balance problems. When we talk about C, we're talking about cerebellar disease. All that means it's a part of the brain in the back called the cerebellum that is causing problems with balance and also a wide-based gait. And it's tough. This is a tough, challenging disease to diagnose. Postmortem studies show that only about 62 to 79% of patients were diagnosed accurately. And there's a delayed diagnosis. It's about almost 4 years before the mean person mean years until symptom onset to diagnosis. And just like PSP, it's rare. It's 1.6 case per 100,000 over 40 and about 3 per 100,000 over 50. Now, how does that compare with Parkinson's disease, which affects millions? Parkinson's disease is 120 to 180 per 100,000. This is 3 per 100,000. Both sexes are equally affected, and usually you see this in the 6th decade of life. So even with Parkinson's disease, there are prodrome symptoms. And prodrome means, what are the early signs? Prodrome means before. And a lot of these patients have REM sleep behavior disorder. Does anyone know someone who sleeps at night and kicks and punches and calls out? Oh, Seinfeld. He He's a little young, but Kramer, yeah. So that is one of the things that you see as a prodrome for not only multiple system atrophy, but you also see this with Parkinson's disease. I know my mom, who died of Parkinson's, did this for years, 20 years. We would hear the calling and the crying out. We're like, what is this? Is that a ghost? Or, I don't know what that is. It was REM sleep behavior disorder. Who knew? And certain clinical symptoms make the diagnosis of an atypical Parkinson's more likely. So you get slow, you get stiff, you get early speech and balance disorder. Whereas Dr. McFarland said in Parkinson's disease, you don't see balance for 5 to 7 years. It's kind of down the road. These patients get-go, early speech and balance. Problems with speech, problems with swallowing. I'm not going to go through all that, but you can see how difficult it can be to make the diagnosis of something like multiple system atrophy. Right now, we don't have a definite biomarker. You'd have to take an autopsy or a sample of the brain. But there are clinically established guidelines for what is probable multiple system atrophy. I like this from verywellhealth.com. These are the early signs. Your slow movement. You may have tremor, you've got rigidity, you're incoordinated, impaired speech, bowel problems, usually bladder control issues. But of note, you don't usually have the decrease in down gaze that you see with progressive supranuclear palsy. Okay. In the time course of this disease, as well as other atypical Parkinson's, much more aggressive than Parkinson's disease. I had a Parkinson's disease patient this week who's had it for 30 years. That's not typical. 20 years, 17 years. But these people, by 30% of them are in a walking aid about 3 years after diagnosis. They have to use a walker. 60% may be wheelchair bound 5 years after diagnosis, which you don't see with Parkinson's disease. Also have, quarter after 5 years of falling daily, severe speech and severe dysarthria. So levodopa is the gold standard for treating Parkinson's disease, Sinemet. And what happens with these patients is they look like they have Parkinson's disease. And they come in and you try them on levodopa and it works for a little while, but after about 3 years, it doesn't work as well. So it's a poor response. And what do we mean when we say, well, we're going to give you a trial of Sinemet? Well, it means that we're going to try you for at least a month, probably higher, or longer rather, and high dose. But the difference here is that these patients have what we call orthostatic hypotension. They can pass out. They have problems with orthostatic hypotension. And guess what causes that? Levodopa. So while we're trying you on high doses of levodopa, we have to be very careful that we're not going to lower your blood pressure, because then we're making the disease worse. We can also do something where we bring patients in and we give you a couple of tablets while you're in the clinic with us. Never quite as good as giving you a full trial. And there are some neuroimaging clues. Again, there are no definite biomarkers, but there is something called the hot cross-bun sign. Does anyone remember a hot cross-bun? Do they make those? Anyway, there it is. I don't have a pointer, but with the red arrow, you can see in the pons the little white cross. It looks like a hot cross-bun. We don't see that with every multiple system atrophy patient, and I think that there are other neurodegenerative conditions that can be marked by this as well. That's what we call a sagittal MRI on a patient. We're taking the picture of you and we're looking in your ear. So we're looking sideways like this, okay? You can see the back of the brain, the cerebellum is very, very small there. Does anyone know what we mean by the autonomic nervous system? What's the autonomic nervous system? Well, it's the involuntary nervous system. So if I have motor function, I'm going to tell my arm right now, I want to put my arm out and I want to move it. That's voluntary, right? You're able to move when you want to move. Autonomic nervous system is involuntary. This is your blood pressure and your respiration and your urination and, bladder and bowel dysfunction. You don't tell your blood pressure want to go up or down. That's part of the involuntary nervous system. And that is affected very drastically in multiple system atrophy. So patients have syncope, they feel lightheaded. If they get up, they feel like they may pass out. That is a problem because it's a leash on the patient. You cannot leave someone at home if they're going to pass out, as are falls. This is a nice slide from Osmosis, and it says, what are the disorders of the autonomic or the involuntary nervous system? There are a lot of things that can cause it. Diabetes causes problems with the involuntary nervous system. It's amyloid, lupus, but it causes you to feel weak and dizzy and tachycardic. And how do you treat it? Well, you have to diagnose it, have to drink a lot of water, add some salt to your diet after talking to your primary care physician, and then you want to treat the underlying cause. I think I'll go past that. So what we do in the clinic, and you may have had this done, is your doctor will or healthcare provider will put you on the table and take your blood pressure after lying there for 5 minutes, and then they'll carefully stand you, and they'll ask you to wait a minute, 3 minutes, 10 minutes, as long as you can, of course, without falling down. Blood pressure has 2 readings, right? What's the top one called? The systolic blood pressure, and the bottom is diastolic. If you're dropping by 20 points when you stand, that can be indicative of someone who's got this problem with autonomic nervous system issue. I like this slide from the Multiple System Atrophy Trust. This is from the UK. 81% of caregivers found that it's difficult to manage problems with speech and swallowing in their loved ones. 73 respondents reported that multiple system atrophy had a severe impact on the quality of life. 97% that said that they have difficulties managing basic life functions. All of them have problems with movement, and I think people with progressive supranuclear palsy would agree with those. 60% are currently in a wheelchair. 14% are totally dependent on a caregiver. So does MSA interfere with quality of life? Yes. PSP? Yes. We work in the neuromodulation center, which is where we put the wires in people's brains when they have a tremor. And I asked people, how is the tremor bothering you? No, it's bothering me. I can't write anymore. I can't drink, whatever. But when I asked the multiple system atrophy patient, I had one this week, and I said, how does this affect your quality of life? And her family thought I was crazy. I said, well, of course it affects. What do you mean, how does it affect her quality of life? It affects everything. She can't walk. She's falling. She's dizzy. She can't go to the mall. She can't take care of herself. She can't, shop. She can't cook. She can't do anything. So it's a much more severe disease. These atypical Parkinson's are very severe, and they affect everything. They affect your quality of life, and they affect your caregiver's quality of life. What's the treatment for this? We try Levodopa. It doesn't really work. It's a poor response. 1/3 of people may get some benefit at first, but the problem is it's limited. It doesn't work for more than 3 years, okay? So as Dr. McFarland said, and we did not do our slides together, but it takes a village. What does it take? No? It takes a neurologist. It takes possibly a cardiologist if you're dropping your pressure. If you've got constipation, you may have a gastroenterologist. If you're not sleeping, there might be a sleep physician. It takes a social worker. You need psychological treatment possibly because these diseases are incredibly demoralizing and they're traumatic when you get them. It's a trauma. You're fighting a war. And you need psych treatment to talk about this. You need counselors, especially if you want to disclose this to your children. You need support group, which, thank God, after COVID, was very useful that we at least have Zoom, and people who are wheelchair-bound can get on a Zoom call rather than having to travel, right? Exercise, medical rehabilitation is vitally important for all of you. Dystonia, involuntary muscle contraction, very painful. And this can be treated with Botox, and that can cause problems too if it goes in the wrong area and cause swallowing problem. Cerebellar ataxia, we still don't have a treatment for it. That's really gait and balance disorder. Physical therapy is vitally important. Why? It's going to help your gait, hopefully help your balance, avoid contractures, keep you mobile, help to avoid falls, and help you to avoid deconditioning. It's very important if you could do a little bit every single day. It's also in Parkinson's disease now, we think that physical therapy can actually slow the progression in some regard with Parkinson's disease. The treatments that we have for Parkinson's are symptomatic. We're going to give you levodopa, and it's going to help your symptoms, but we can slow the progression a little bit if you exercise every day, and I would recommend that you all look into that also. Occupational therapy. It's very important that you keep a person, as to the best of your ability, performing daily tasks. Independence. Hey, occupational therapy can help you maybe use a walker, daily routine, getting dressed, brushing your teeth. And occupational therapy can also come in and maybe look at your house. Maybe there are things that aren't safe, like you have a throw rug, or you need a grab bar or in the bathroom or something. So that's very important. And speech therapy is very important too. Here's just a few more things about multiple system atrophy, but I think they're pertinent to the atypical Parkinson's as well. Swallowing issues. Swallowing can be terrible in atypical Parkinson's, multiple system atrophy. Reduce your meal volumes, eat slowly, work on your posture, okay? Maybe you need a little thicket. Drooling, major problem with atypical Parkinson's as well. There are anticholinergic drugs that you can try, but they have side effects as well. You can use some Botox to try to Botox the salivary gland, but that can cause some swallowing issues and can aggravate the problem. I'll go over here, multiple system atrophy, the orthostatic hypotension, where you feel like you're going to pass out, or you have these dysautonomic problems. Very important to drink water. I know none of us want to do it. Why not? Because it makes us urinate, and too much, right? But it is very important. Many patients have a low blood pressure after a big meal. It may be better if you take smaller meals more frequently so you don't drop your pressure. You may need a medication to keep your pressure up, but you should talk to your primary care or your neurologist about it. That has to be done with a healthcare provider. Okay? Also, watch out if you have low blood pressure. When we give you medication to keep the pressure up, when you lie down at night, your pressure will go very high. It's possible. So you'd have to sleep on a wedge, almost like you have to put your bed up on blocks. Okay? Okay, gait and tremor. We've talked about treatment of bladder. Bladder is a major problem with multiple system atrophy. Some patients have to catheterize themselves every day. Some patients have to catheterize themselves 3 or 4 times a day. There are medications that can be tried for this. Something like Myrbetriq, for example, that doesn't get in centrally, but there are side effects to this too. So it's good to ask your primary care or your neurologist about a medication for bladder dysfunction. Okay. Pain is one of the more common symptoms of Parkinson's disease and also multiple system atrophy. You wouldn't think it, right? But it occurs. There are contractures. Sometimes you get what we call a coat hanger pain right here. And if you have a low blood pressure, it's that the blood and the oxygen is not getting to those muscles. So it's important to tell your primary care or your neurologist about that. We can think about some medications to try to treat the pain. But Parkinsonism can be a painful condition, which is not well known. Mood symptoms are huge. Anxiety, depression, mood lability, psychiatry, psychology, counselors, mental health, not only for the patient, but for the caregiver and the children. Extremely important. There's a lot of depression and there's a lot of demoralization with this. Sleep symptoms, extremely important if you have stridor or you have obstructive sleep apnea. The stridor is that noisy breathing that can occur. This necessitates a consultation with sleep physician. Sleep dysfunction can be a cause of death or a shorter survival time in patients with atypical Parkinson's, so it's very important to get to a sleep specialist. Nowadays, you don't really have to go and get a sleep test and go and sleep in a place. You can actually have the sleep test done at home. Constipation, if it's Parkinson's disease or any of the Parkinsonisms, this is a major problem. Increased water, exercise helps, perhaps even a stool softener, other medications, and fiber can help. Be careful of the fiber. It's good, but it can make you feel bloated. So my team and I we're writing a paper on the research in multiple system atrophy, mainly because I knew that I was going to come and had the honor of talking to you folks today. And what we found is very interesting. In the last 40 years, we found 50 double-blind placebo-controlled trials. 50. Not that there's not hundreds of research studies in multiple system atrophy. We're talking high-quality, double-blind, placebo-controlled. I don't know what you're on. The patient doesn't know what he's on. I'm going to randomize it. These are studies that would lead to a registration for a drug in multiple system atrophy. So I do have better news towards the end. Most of the studies pertain to the abnormal alpha-synuclein. There was a large study that was just done that was negative, very well-run study. But with the exception of 2 small studies that showed the intrathecal delivery of stem cell that showed some benefit, most of the studies have been negative. Why? Maybe there weren't enough patients. Maybe we got the patients too late in the disease. We don't have a biomarker. We would like to do this early on in the disease rather than later. Now, the good news is that if you go on clinicaltrials.gov, I saw 10 new clinical trials in multiple system atrophy. So clinicaltrials.gov. No matter where you live, you can look up and see if your neurologist can look at that and talk to you about wherever you live in the United States, possibly entering a clinical trial. Some of these are from Korea. They're outside the United States. Some of them are Japanese. But many of them are European and in the United States as well. And these have to do with stem cell, like oral mucosal stem cell, also monoclonal antibodies. Without getting into the specifics, these are antibodies that target the abnormal protein called alpha-synuclein. There's at least 2 of those. There's another on glial cell line-derived neurotrophic factor. KM819, small molecule inhibitor of Fas-associated factor 1, which is a key regulatory protein in cell death. Also intrathecally administered mesenchymal stem cells and multiple system atrophy, one coming up there. And the last one is ION464, another intrathecal injection of what we call ASO therapy. Very involved, would take another talk, but good news is that there are about 10 of these clinical trials. So even though we've had negative results so far, there's, I think, a lot of hope for the future and a lot of focus on the atypical Parkinson's in terms of treating them. Well, I made it under, so I want to thank the CurePSP. I want to thank you, Dr. Diaz, Dr. Golby, my Floridian colleague, Dr. McFarland, Jessica Scherer, and all of you at CurePSP. It's an amazing organization, and thank you for coming.